Yeah, so Zoom people, you can just unmute yourself and talk to try to answer questions, or you can use the chat, whatever you think is better. This is a new experience, so just bear with me. Okay, so my topic today is called neurovascularly intact. It's a phrase that doesn't mean very much, but you hear it a lot. You hear people, ortho will ask you, like, is the patient neurovascularly intact? And sometimes you're tempted to just say yes, but you should try to understand what you're saying when you say yes to that question.
On your desktop.
All right, so thank you to my team that helped me edit my slides, some of which was at the last minute. Okay, so today we're going to review X-ray, fracture, and dislocation patterns in Fuchs injuries. I chose Fuchs injuries because we see them a lot. It's very common. You're not going to get through your EM residency without seeing somebody fall on an outstretched hand, whether it's a child or an old lady. Those tend to be the two groups that do it the most. We're going to talk about the mechanism for neurovascular involvement, and then talk about physical exam findings and also documentation. So these are the two groups that fall the most onto their outstretched hand. So first we have toddlers. Supracondylar humerus fractures are most common in toddlers. Older kids can get distal radius fractures, and you'll notice, or you might hear about Torus and Greene stick fractures in particular. And then adolescents and young adults are more likely than younger kids to injure the carpal bones. And distal radius fractures become more common with age. Okay, so first, interactive question. Where is the fracture? Anyone? Just take a guess. You see an elbow. Right. Anyone?
I think some of it's
Do you read the second?
Old bone or a new bone?
What?
Is it an old bone or a new bone?
Well, so the point is, like, just to give me like a rough estimate of where you think the fracture might be, you know.
Probably like supracondylar.
Yeah, thank you. Supracondylar. Okay, so we're going to talk about fat pads, okay? Because you might not have seen the fracture. But so fat pads are basically a good sign to use because you don't always see the fracture in supracondylar fracture, right? But if you see a pathologic fat pad, then there's probably a fracture there. We don't know 100%, but roughly. Okay, so what happens, this is just a demonstration of how fat pads are formed. So ordinarily the two yellow fat pads are closer to the bone, right? When you have a joint effusion at the elbow, you have hemarthrosis that displaces the fat pads upward. So this is a normal anterior fat pad. I don't have like a flicky thing, but does everybody see where it is? Like the black shadow on the anterior aspect of the humerus? Here's an image similar to the one I put up. Maybe it is the same one, I can't remember. But that is a pathologic anterior fat pad because you'll see that it's like coming out, right? And if you think back to that picture that I just showed you, you can actually see how the hemarthrosis pushes it upward and outward. So instead of being like a narrow, dark line against the humerus, it's more like the sail side, which you may have heard about when we're studying. And here is a picture of a pathologic anterior fat pad and posterior fat pad. So any posterior fat pad is pathologic, and anterior may or may not be, depending on how it looks. Okay. Any questions? All right. So does anyone know what are the X-ray lines that we can use to help us identify dislocation and fracture in supracondylar injury? So here are some options. You have the ulna capitellar line and posterior humeral line, radiocapitellar and anterior humeral line. C is with the posterior humeral line, and D is the subcondylar line flavus and line of Galeostomy. Anyone? Here, B. Great guess. That is correct. D is not real. That's great. Okay. So next, we're just going to talk really quickly about the ossification centers and the lines. Sorry, these were supposed to be in a different order. So the lines, this is the answer, right? B. So you have the anterior humeral line, which is drawn on the, it's easy to remember. It's the anterior aspect of the humerus. And then the radiocapitellar line is just going to be drawn right through the radius into the and through the middle of the capitellum. So in a fracture, you might see that the anterior humeral line would, it's supposed to pass through the anterior third of the capitellum, or sorry, it should pass through the middle third. When it's pathologic, it might pass through the anterior third or in front of it. Okay, you can look up pictures of that. And then radiocapitellar line, that's the yellow line. That one should go right through the center. And because the radius articulates with the capitellum, when the radius is dislocated, it will not pass through the center. Okay. And a good thing about checking for this line in particular is that it will force you not to miss a radial head dislocation. Because sometimes you might be focused on a fracture, a fat pad, and you might miss the radial head dislocation, which would be a non-major fracture. Okay. Oh, so and then. And then, let me go back here. This mnemonic, if you remember it, great. You might forget it, and that's fine. Just maybe you can Google it. But that just reminds you of the ossification centers, because sometimes you'll think it's a fracture, right? And it's just a space for an ossification center, especially in these fractures because they happen in kids a lot. Okay. What nerve is most commonly involved in supracondylar fractures? This is kind of a trick question. Tricky. Anyone want? Oh. Anybody on the Zoom chat want? Oh, I see B, median. I'm seeing a lot of median. This is why it's such a trick. Median is not wrong.
Yeah, C.
C, I'm hearing some C's. All right, looks like the room has it today. Sorry, Zoom. The answer is C. Okay, so this is why I was tricking you. So just remember that the median nerve, there are high median nerve lesions and low median nerve lesions. One of the things that got me interested in doing this lecture is I kept wondering why I was reading on ortho bullets that the anterior interosseous nerve was the most commonly involved nerve, because it doesn't really make sense. Because it comes off after the elbow, right? So how would that happen if you have a supracondylar fracture? So it turns out that the anterior interosseous nerve fibers run on the bottom part of the median nerve. So that's why it was actually not a great question. I just wanted to see if everyone was paying attention. But technically the median nerve is damaged, right? But it's the anterior interosseous nerve fibers that are damaged. So if you're just testing the median nerve, and not specifically the anterior interosseous nerves, you might miss it. So good to just remember that they're two separate, there's two different ways to test it, and we'll get into that on the next slide. Okay. Any questions about that? And it's either from, the fracture itself in a supracondylar fracture, or it can just be from the stretch of the fibers of the anterior interosseous nerves, because remember that it's attached to the fascia. I don't know if anybody remembers from anatomy, but you had to really dig to find it in the antecubital process. So it's really attached there and tethered, so that if there's displacement of it's usually an anterior displacement of the humerus and a posterior displacement of the lower part, and that can basically shear the fibers. Okay. So it's anterior interosseous, but technically it's median. So but I'm talking about the anterior interosseous nerve here. So which exam finding tests this nerve? So top one, whatever. Anybody want to call it out? Top left, top right, Bottom left, bottom right,
Not right.
top right. I'm hearing a lot of top right. Ooh, I'm hearing some thumbs up. Okay, answer is, oops. Oh man, I didn't do the circle thing. Okay, it's top right. Okay. So just very quickly, this one here, this is wrist drop, right? The top left. So that's testing radial nerve. The one next to it, the correct answer, this is anterior interosseous. Just for, if you wanted to test a high median nerve lesion, the best way to do it would be to test the pronator. And so basically ask the patient to pronate, but give them some resistance and see if they can do it. And then this is ulnar, the bottom left is ulnar. So you want to make sure that the patient has their hand flat, and then you want to test the interossei muscles by having them adduct against resistance. And then this is posterior interosseous. So similar to median and anterior interosseous, posterior interosseous is branch of the radial nerve, and this, this would be like probably associated with a high radial nerve lesion, and the posterior interosseous tends to be more of the distal radius fractures. Okay, try to speed it up here. Anybody know where the fracture is here? It's a little more obvious.
Yeah, distal radius.
Good, distal radius, awesome. So these are some fracture patterns. I think most people are familiar with the top left, the Colles fracture, right? That one's the dinner fork deformity that you see in a lot of like elderly people that fall. Smith is something you might see in a high energy mechanism. So maybe in a kid that has a high energy mechanism, you might see that tends to be associated with younger people. And that would be volar displacement on this side. So here is the classic dinner fork deformity seen in old ladies. These are usually extra-articular and stable, like you see in the cartoon image, and that would mean, we could reduce it, or they can reduce it, but you can basically reduce it and splint it. It doesn't need emergent ortho consult. But if there is any, and we'll talk about what are the major things, but any intra-articular involvement is a big thing. If it's an oblique fracture or a comminuted fracture, and then there's specific radiographic findings we can talk about in a second. Those are things that would point you towards getting ortho involved sooner rather than later.
What can be very useful in the wrist fractures, particularly like the Colles and the Smiths and the Barton, is if you're not sure the extent of it, is getting a CAT scan in an adult. And that can tell you if there's joint involvement in it. Yeah, so Dr. Greene was just saying that if you're on the fence about whether there's joint involvement, you can get a CAT scan. And that's a great point. It will give you more subtle views to see if there's intra-articular involvement. Oh, that was Smith. Less common. I'm not going to get into it too much, but also important to recognize. And here, they also wanted to point out to you that if you look on the right image, left image, there's a avulsion of the ulnar styloid process. It's a little subtle there. So which nerve is most commonly involved in these distal radius fractures? This is not a good question. I'll give you a hint, it's the same.
Yeah, radial nerve.
It's median, again. It's always median. You only need to know one exam. That's it. I'm just kidding. Okay, so documentation, just quickly. So fracture description. So these are just things if you want to push yourself to, really describe the fracture appropriately to your ortho consultant. Obviously, you want to tell them if it's closed or open. You want to tell them if it's extra or intra-articular. We talked about that. That would prompt you, maybe you could say, I think there might be intra-articular involvement, but I'm not sure, so I went ahead and ordered a CT scan. They always like that. Configuration. So if it's transverse, that's simple, right? Oblique or comminuted, a little more involved, probably get ortho. And then displacement, radial tilt, length, angle, and intra-articular incongruity. And then if there's ulnar or distal radius ulnar joint involvement, so any fracture at the tip, mid portion, or base, or subluxation or disability, those are all more complicated fractures. So this is an image of radial length or height, measured always on a PA view. top line is just drawn from the, it passes through the distal tip of the radial stylet, and the bottom one intersects the distal articular surface of the ulnar head. So this is the average vertical distance that you want. If you have radial shortening, you might hear that a lot, that would be pathologic. Radial inclination or angle, also PA view. So that's the angle between one line connecting the radial styloid tip and the ulnar aspect of the distal radius, and a second line perpendicular to the longitudinal axis of the radius. Normal angle would be 21 to 25 degrees, and if you have loss of radial inclination, that would be pathologic, and you would have an increased load across the lunate. And then this is radial tilt. So this is the angle between a line along the distal radial articular surface and the line perpendicular to the longitudinal axis of the radius at the joint margin. So just, you know, you might forget these things, but you can always look them up again. Just remember radial height, radial angle, and radial tilt. So these are indications for a reduction of distal radius fractures. So if the dorsal tilt is greater than 10 degrees, any articular step off, radial shortening we talked about, and radial inclination less than 15 degrees. Okay, so just to review the neurovascular exam. So you have your anterior intraosseous, right? And median, you would maybe test the pronator, that's one option. Posterior intraosseous is the branch of the radial nerve. This is posterior intraosseous, right? Just more proximal radius would be wrist drop. Ulnar nerve, it's pretty easy, it doesn't have to branch really. You just do the, you know, have them lay their hand flat and try to squeeze their fingers together. Sense and try to, you know, get comfortable with sensory and motor. I didn't do sensory, but that's something you can look up, and or so most of you probably already know. And then signs to look for: tenderness, hematoma, erythema, swelling, step-ups. Anything that doesn't look normal, you know, probably broken. I know we had a good M&M a while ago about a nursemaid's elbow that actually was a supracondylar fracture, I think. So, you know, remember that the different fracture patterns. If you hear that somebody fell on their arm, be more concerned for a fracture, and especially a supracondylar fracture if it's a kid, as opposed to a nursemaid's elbow, which is more of a dislocation. And they, you know, if there's swelling and hematoma, that's more concerning for fracture. And always repeat your neurovascular exam after you split the patient, because a lot of these problems can happen from like compressive neuropathies just from the cast, a lot of the neurovascular complications. So these are just quickly other FUSH-related injuries to look up and think about. I mentioned Greene stick and torus fractures because those are the common ways that you might see a distal radius fracture in a kid. Barton's fracture is a high energy distal radius fracture. Scaphoid and lunate, perilunate, those are the carpal bones, and I didn't get into any of that today. This is a poem that I wrote to the phrase neurovascularly attacked. This is my final slide. So it's, oh, neurovascularly intact, I turn to you. 6:45 p.m., desperate to leave on time for once. Silverbird's ire breathing down my neck. Where's your note? You owe me a note. Nose to grindstone, I start to type on physical exam. Patient is neurovascularly. Don't fall for it. You're better than that. Neurovascularly intact is nothing but a crutch. So document a real physical exam. Don't just write neurovascularly intact because it doesn't mean anything. Any questions?
I thought that was a very good and helpful review.
So for the supracondylar fracture, is there a way to use ultrasound to identify posterior fat?
Okay, so JFK is asking if there's a way to use ultrasound to identify a supracondylar fracture.
Is it perhaps even more sensitive than X-ray to identify?
It may, in fact, even be more sensitive than X-ray.
I agree, I read that somewhere. So yeah, it's actually an incredibly easy exam to do. I mean, and for those who have done with me, like some of the others, it really is just linear probe. You're going right behind there, looking like cubital ectoron fossa, straight across there, and you see billowing of synovial fusion into like the tricep tendon. Simple. So
Okay.
you see that on the pet sign.
So I'm just going to repeat what JFK just told us for the Zoom people who can't hear. So he's saying you can put a linear probe right here, and look for fusion into the triceps tendon.
Basically just kind of billowing out. You see a nice straight line, the tricep tendon. If you don't see a straight line, something bad's going on.
Yeah, so if you see a straight line for the triceps tendon, no problem, but if it's billowing out a little bit, there could be an effusion. So look for the triceps tendon right here, the linear growth.
Thanks, Andre.